to the microphone just to kind of get you warmed up. First up, let's hear any questions of clarification that you had. If you could just indicate by raising your hand straight up in the air if your table had some really interesting questions that you'd like to kind of bring up right now. I'd ask you, let's maybe hear 2 or 3 of them. Could you start by saying your name and kind of where you're from quickly, and then your question?
Good afternoon, Jeannie Solis. I'm from Louisiana. And the question I have for clarification, Dr. Satcher, is regarding...
Why doesn't the microphone work? That's a good question. Excellent question.
All right, is regarding mayors and your graduates from the leadership program. In Louisiana, we have a new piece of legislation. It was just signed by the governor this summer for obesity prevention. It's called the Workout Now Act 187, and it charges mayors and elected officials to take on obesity prevention and do something. It's just in formation right now with the new commission. So I'm curious, what clarification could you give about how mayors could be involved in obesity prevention?
Yeah. Justin?
Yes.
Yeah, it's interesting. The first mayor to go through our program was Mayor Johnny Ford from Tuskegee. You know, Tuskegee is known for a lot of things. It's really a small town in Alabama, not too far from where I grew up. But Mayor Ford, who's involved with some international organization of mayors, thought, based on his experience, that it would be very helpful. Number one, it would be motivating for them to learn more about how obesity relates to diabetes and go on and on, cancer, heart disease, and but also what kind of strategies have been successful in helping to stop weight gain or decrease or weight loss. So the idea was that these mayors would come and learn, but they also would share, and we would become better. And I can testify that we have become better at what we do by learning the community from their perspective. You know, I've done a lot of things, but I've not been a mayor. I don't know what it's like to fight with the city council and the government and others to try to get things done. But I also am not motivated to do that, but I'm motivated when I hear them discuss what they do and what we can do together. Basically, we're developing new teams for community health. As people go through the program, hopefully our ability to work together in the future become, I think the Casey Foundation has funded us to bring in more mayors because they feel that that's a very important strategy for developing new teams in public health. In other words, one thing to say public health is the collective efforts of society to create the conditions in which one can be healthy. But that collective takes on new meaning when you have, you know, somebody in the mayor's office who is motivated to work together with public health and knowledgeable about what we can do together. That makes sense.
Thank you. Next question.
Hi, I'm Carmen Yanes from Austin, Texas, and I had a follow-up question for Dr. Satcher or anyone who wants to answer this. I think it's really important, and I'm glad you brought up the children standing at the fence analogy and talking about equity, and I think it's incredibly important for us to understand how we got to inequity in order to talk about equity in the first place. So I would just love to hear a little more clarity on where you think some of the root causes of inequities come from.
Well, the question is, what are some of the root causes of health inequities? Well, I mean, obviously, if you look at history, it becomes very clear that historically, we have not had the same opportunities, I mean, historically. And if we're going to change that, I mean, to the extent that we definitely need to change, we need to know more about what it's going to take for everybody to have the opportunity to be healthy, equal opportunity to be healthy. I think We're going to have to educate people at every level. And again, that's the whole purpose of saying, yeah, you've been to school, but we can continue to educate each other as we have different experiences in public health, in the mayor's office, in churches. And I should say churches have been a major part of this. When we wrote the pastors in the community, we asked them to recommend somebody. I remember that almost right away, about 50 of them recommended themselves. And when you think about it, that's a good thing. And that's a very interesting program going on in the community, which started in churches. Because the church is a really key institution in our community. It really is. And the more knowledgeable and committed the church is to helping the community to be healthy, the more likely we are to be successful in any of our programs. There is a NIH-funded program at our institution that's centered primarily in a black church downtown dealing with diabetes. And the whole idea there is self-management of diabetes. And you probably know the church is with Big Bethel. It's one of the largest churches. So, I just think there are opportunities there. And the closer you get to the community, the more you're going to understand what's needed, and the more successful you're going to be when you try to implement it.
All right, I'm going to capture a couple more questions. If there are more questions, I'm going to ask Dr. Satcher and the panel just to refrain from answering just yet. I want to capture them here, give you an opportunity to hear some more from the panel, and then re-immerse into this conversation itself. So let me capture the questions that you have so as to ensure that we do not miss them when we're having a discussion once the panelists have completed their presentations. So go ahead.
Thank you. Good afternoon, Dr. Satcher and everyone on the panel. I'd like to know a little bit more about how we can bring the opportunities that you spoke of in regard to the healthcare policy leadership fellow opportunities, in addition to the initiative that you just spoke of, helping to train leaders in faith-based communities. That's something that I would definitely like to see in terms of even reaching back to those students who are currently enrolled in public health programs in higher education to help prepare them as they're coming out. Could you speak more to how we can go about bringing more of those opportunities for fellowships?
Yeah. He'll speak to it, but I want to make sure I capture your question, which is one of how do we actually ensure that we have this pipeline of leaders who will make a difference in this specific issue? Or do we use those programs to make that happen? I've captured that question. Jean, I want to recognize the chronic disease director here in Georgia, who's with us. How are you doing?
Good, thank you.
Yes.
My question is also for Dr. Satcher. Dr. Satcher, you talked a little bit about the effort to eradicate polio globally, and I'm wondering, what's the equivalent in your mind, kind of strategy or intervention or set of interventions to eliminate disparities in obesity, especially childhood obesity, in this country and around the world?
Thank you. How do you kind of make it happen for obesity, specifically childhood obesity, in a way that kind of connects to the story we've heard about polio? Got it.
So you're going to re-ask these questions?
I'm going to have all these questions re-asked. I just want to surface the questions just now so that everybody's voice is heard before we end. Are there any other questions or clarifications?
Chris, our group had a discussion about rural versus urban and how those of us that grew up in a town of 600 often think those in the city have more opportunities, and those in the cities think those in rural areas are living on farms with, as Nishi said, a farmer's market in their backyard. So if there could be discussion among the panel about inequities in urban versus rural settings.
Thank you, Debbie. All right, this will be your last opportunity, but I want to ensure that you hear from our panelists who bring specific perspectives to this particular matter that we're considering. So I want to introduce our panelists. They'll speak for a few minutes, and then we'll kind of go right back into the conversation, because we really do want to have a conversation this afternoon. So first, I'd like to introduce them all together, and then they'll get started. Harry Heiman, who is a clinical associate professor in the Division of Health Management and Policy at the School of Public Health at Georgia State University. Prior to joining GSU, he was the director of the Division of Health Policy at the Satcher Health Leadership Institute at Morehouse School of Medicine. He's a fellow of the American Academy of Family Physicians, and his work is focused really at the intersection of health policy and health equity. So he'll bring a kind of policy academic perspective. After he speaks, you'll hear from Dr. Leandris Liburd, and she is served in the capacity of the Associate Director for Minority Health and Health Equity at CDC since 2011. In that capacity, she's been leading a lot of work that focuses on the issue around minority health and health equity across the country, including women's health and inclusion management. She's been instrumental in building capacity across the CDC in this conversation around health equity, and a conversation that aims to address the social determinants of health. The third speaker is Mr. Michael Sells, who is currently a public health advisor on the Advancing Population Health team in the Division of Heart Disease and Stroke Prevention at the CDC. He's also the chairman of the National Center for Chronic Disease Prevention and Health Promotion, Health Equity Work Group at CDC. Prior to joining them there, he's served in numerous roles. You can look at his bio, you realize that he's gone right across the kind of age continuum. Currently, he is a doctoral candidate in PhD with a concentration on community health promotion and education. So he'll probably bring us now a very practical kind of view of this issue of health equity. Could you please welcome them all together? And as they come to the podium, celebrate them individually. So let's do it together first. And then could you celebrate as he comes, please, Dr. Harry Heiman.
I just wanted to clarify whether it was a few minutes or a few hours. I was prepared for a few minutes. I could go a few hours, which would be really painful on both sides of the microphone. So it's a pleasure to be here, especially with such an esteemed panel and such an esteemed audience, and most especially with my former boss, Dr. Satcher, from whom I've learned so much. I really think that we're at a critical time in history. I won't take that where you think I'm going to take it, but it is a really critical time in history, and it's a particularly critical time in history for us to reframe some narratives, to reframe some stories about what is and isn't going on in our country. And that's as true about obesity as it is about many of the other pressing issues in our country, whether it's inequities related to educational opportunities, inequities related to community-level violence, which Dr. Satcher alluded to, or the widening disparity in income inequality. And I think the narratives kind of go like this. It's the bootstraps narrative, right? Everybody knows the bootstraps narrative, where we're all born with the equal opportunity to pull ourselves up by the bootstraps, and if you work hard enough and you persist long enough, you can realize anything that you choose. And it's a great story, and I like stories, and I like fairy tales, and as a child they were really entertaining, but the reality is that's not based in our current reality, nor is it based in our historic reality. Now, I grew up in a family where my father was a refugee from Nazi Germany, and he picked himself up by the bootstraps together with his loving family and the educational opportunities that he had and the job opportunities he had, and he made himself into a success. But he had a lot of people pulling in his direction despite the many barriers. The reality is and the alternative narrative, which I think is based in reality, that we are all either beneficiaries of or victims of the neighborhood and zip code in which we are born, and the families and the opportunities that those families provide for us, or by virtue of dysfunction and barriers which maybe our family members couldn't get over, challenges that we had to try to work through and persist through, sometimes successfully, sometimes unsuccessfully. But this idea that obesity is a condition driven by personal responsibility and individual choice, and that's all it is. And we all can either make good choices or bad choices, and that determines whether we're thin or heavy, is a fairy tale. It's a fairy tale based on the narrative of equal opportunity, and I think health equity is very much about, as Dr. Satcher said, and as he taught me, providing everyone with equitable opportunities to make healthy choices. But that requires us to assure the conditions for people to make those choices, and assuring those conditions. And really the difference between equality and equity is matching resources to need, right? The difference between the small stool and the tall stool, or a small bicycle or a tall bicycle, or a bicycle that you can do by hands if your legs don't propel you well, is providing resources relative to need. And in the same way, we know in education that for a child who learns differently requires different resources than one who is, quote, gifted, in order to provide people with equal opportunities and equitable opportunities around being healthy and being a healthy weight. It means affordable, healthy foods, and it means not only affordable but accessible in other ways. It means there can't be a major road without crosswalks between where you live and where you buy foods. And it means that where you work, the vending machines can't be filled with unhealthy choices. It means, as our former CDC director said, we want to make the default choice the healthy choice. I think the other thing that's critical in terms of health equity, and I can't remember your name in the back, but your question about history. If you want to understand where we are today, study history. It will tell you, and particularly with regard to health and regard to opportunities. If you want to understand why racial and ethnic minority communities, for example, are 15 to 30 times more likely to be living in communities where there is concentrated poverty, Google mapping inequality and look back to redlining in the 30s, and you will understand that. You not only understand why we have income inequality, but you understand why people are living in different kinds of communities which are framed by the opportunities that they have. Not that equal opportunity that we all aspire to, but the opportunities they have. So I thank you, and I look forward to questions and discussion.
Good afternoon, everyone. First of all, I just want to thank and congratulate the Planning Committee for the Southern Obesity Summit. I want to thank you for the invitation to be here. I was born and raised in Richmond, Virginia. I'm a Southerner in every way. I have both a personal and a professional interest in this issue, in that having been born and raised in de facto segregation, I understand issues of identity and body image and self-esteem that's related both to food, to activity patterns, to how we view ourselves in the context of our community. If you were to ask anybody where I came from, how to describe me, they would say I was thick, big bone, plus size, stout. They wouldn't call me obese. And so this whole issue of kind of obesity as normative, if you will, is something that I think we haven't really grappled enough with in health equity, because health equity really is about context. And so I just wanted to speak a minute to some of the cultural context that we really need to be sensitive to when we are working with particularly racial and ethnic communities. One of the things that in my dissertation work, I actually studied obesity among college-educated African-American women, and I won't start to talk about that because I'll also be here for a very long time, but one of the questions I was trying to answer is why high socioeconomic status did not protect African-American women from obesity as it appeared to protect white women, where if I had a graph, I could show you, again, this was in the early 2000s, that there was an inverse relationship between like body size, income, and education when you looked at white women. So the more highly educated they became, the higher their incomes, the thinner they became. But when we looked at that same data for black women, it wasn't that striking. I mean, we saw a slight drop, but it wasn't this sort of thing. Okay, so as I explored some of this, particularly through from the standpoint of medical anthropology, so there are issues of like what I'm going to call sociality and traditions. So, you know, there are certain foods that go with certain occasions, right? You don't serve sushi at a Super Bowl party, right? And I know, you know, recently I was with some friends from college. We got together for a birthday weekend, and we went to a restaurant, and I actually ordered, it was like an egg white omelet or something, and fruit, and one of my friends says, how boring. So I wanted to understand that kind of what we eat and kind of how we engage with people. It's very social, and it's very part of our connectedness, and I don't think we've really dealt with that a lot. The other thing I want to mention I don't think we pay enough attention to is the whole role of stress and trauma in obesity, particularly in communities of color. And while I'm not doing this work every day, I'm always kind of drawn to it. And I remember when Alton Sterling was killed in Baton Rouge, Louisiana, and I was, you know, watching the news, and I remember his son, you know, they had him come, and he was very large. He was 15, he was very large. His mom was very large. And as I looked across, you know, the people in the community who had rallied to support them, again, kind of going back to my research, I was just drawn to that, to just sort of how large very young people, you know, were. And I could then imagine that their food environment was characterized in a particular way, that like the day-to-day stress and kind of how we internalize these kinds of inequities and injustices would bear on weight. And we know that from the Adverse Childhood Experiences Study, which has been a many decade-long study that CDC has been doing, that early on exposure to certain adverse experiences and trauma will set children up for chronic diseases later. So I just wanted to put that out there. I think that there's a huge role of stress that professional Black women in particular, as I have studied them, as I am one, that we negotiate every day that also bears on weight. And then there's the whole issue of social support and needing to have buddies. I've given a lot of talks, and people will say, well, I want to do that. I want to exercise more, I want to eat better, but I don't have anybody around me who will join me in that. And so this whole issue of creating support systems and being intentional about that is something I think we need to spend a lot more time doing. But there's a national program called Girl Trek that actually our office has just started to do on their email, and they like every month have some sort of challenge to get particularly women and particularly Black women, out and walking. And it's not just about walking, but it's about creating systems of social support and giving the women who are walking together an opportunity to talk, candidly, transparently about whatever their day-to-day issues are. And so I just want to stop right there and say that these are some of the issues for me that I think are particularly relevant as we are wanting to reduce racial and ethnic obesity disparities.
So, good evening. Good evening. So, I wanted to say I'm really honored and it's a privilege to be here today on many levels, but just to sit here with my former supervisor and then my director, who was one of the person, as I told him, that I admired, and he kind of helped me to kind of chart my personal career path as it is right now. So I want to just thank you guys for this opportunity to be here. So as one who has worked in nutrition, physical activity, and obesity, but who is now working in heart disease and stroke prevention, I'm encouraged by this opportunity because the risk factors and the issues that are being addressed here in this town hall session and this conference are issues that directly impact the work that we do to address heart disease, hypertension, and strokes. So I'm hoping that I can contribute to this conversation by providing input from a public health practitioner's perspective who works as a project officer and who's also worked on the state and local level. And so that's what I currently do. And so when it comes to addressing the social determinants of health, when it comes to how we eliminate health disparities and achieve health equity, for me, it's just been a part of my personal mission. I could say my calling. So when I decided and I made an active decision, and I was kind of really proactive in terms of where I wanted to be and who I wanted to work with in order for me to be an advocate on behalf of those who are underprivileged and underrepresented. So it wasn't an accident that I had an opportunity to work with Dr. Liburd. It was intentional. Now, it got to a point later in my career where I became more unapologetic in my work. So that meant that when I do my work and when I work in the areas that I work in now, I'm more concerned about how I can best fulfill the needs and be an advocate on behalf of the hundreds of thousands and millions of individuals out there who don't have a voice, as opposed to my colleagues who may not be comfortable right now with this topic. So I'll share that much. So in moving on from there, I'd like to talk to you a little bit about this work from a federal perspective and from a state and local perspective. So from a federal point of view, it's important to be an advocate, to follow the data, to serve as a guide, to implement and promote policies that support our work. So when I say to serve as a guide, there are a lot of times, as many of you know, when we're trying to promote this work of addressing health disparities, or actually of eliminating health disparities and addressing the social determinants of health, we are not always met with open arms. Okay? So that just comes with this work. In addition to that, the policies that we have to support sometimes. For example, in our center, there is this notion now of the dual approach. And it was a recommendation that was made by the Health Disparities Subcommittee, which was a subcommittee that was brought of seniors and experts to CDC to provide us with recommendations. And again, one of the major recommendations was to implement what we call the dual strategy. And that is simply divert resources and energy to the general population as we do with our work, but also ensure that resources and energy are also directed to those populations who are bearing the highest burden of disease. So that's something that in our center we've definitely tried our best to adopt. And those of you who are familiar with our state and local public health actions funding opportunity is familiar with that as 1422. That's an example. And so that's an example I like to share in reference to how things happen on the federal perspective. So from a state's perspective, again, it's important to follow the data. The data won't lie. It's also important to stay with my notes here, and apply a health equity lens to our programs, our policies, and to evaluation. What's not evaluated a lot of times are things that are not sustained. So it's important to do that, as well as to utilize all of our human, technical, and financial resources when we do this work equitatively when it comes to addressing health disparities. And so with that, I'm going to just try to talk a little bit about some tools and resources that may be helpful to us as we do this work. For example, it's important to gather the relevant data and proactively address the social determinants of health. A lot of times, people when we talk about social determinants of health, it's this pushback sometimes that this is outside the realm of public health, but actually it isn't. Okay? And so one way to do this is there's a tool called the Health Opportunity Index. And this is the opportunity to use statistical data to isolate and basically analyze the social determinants of health. I don't have slides or anything, but if you pull up the Health Opportunity Index, it's an example of a tool that can be used, as well as what's becoming popular now, the GIS mapping capabilities. I know our division, we conduct trainings around this area. Many of you are familiar with GIS mapping, or you have someone in your health departments who can play a role in your work in terms of GIS mapping. And this is very important because GIS mapping allows us to pinpoint where the geographical disparities are. The question around rural versus urban issues was raised earlier. Very different landscapes, similar risk issues that they're dealing with. So the ability to use your GIS mapping capabilities to do this work will definitely help to inform your work. And then there are resources such as online inventories that can be used to assist public health practitioners with identifying the resources needed to address the social determinants of health. So here's another issue. We've decided that, yes, social determinants of health are important, but what do we do next? So we have patients and clients and the populations that we've identified who are in these pockets of communities or parts of the state that basically are in deserts when it comes to certain areas, or are unsafe when it comes to certain things, or who may not know how to access resources. So here's a couple examples of some resources. There's online inventories that I think are very useful tools in accessing or helping practitioners and populations to access social and environmental determinants of health. And one is called Community Commons. Okay, so some of you are nodding, but if you Google Community Commons, there are a few states, or actually communities right now, who are using this tool, and one of them is Los Angeles, and I work closely with them. Another example is called 1 Degree. If you look up that one, it also is a very helpful tool and resources. And so I'll stop there. Again, my role here is to kind of input when I can some information that I may have that are kind of from the practitioner's perspective. But also, I just want to thank you again for this opportunity.
Thank you to all our panelists. You've heard 3 different perspectives and yet connected. You got a sense from Harry a little bit about both historically kind of what's driving this, or what we should be thinking about as we're thinking about some of the solutions and fixes. you heard both a personal and professional kind of take of the issue with this concept of sociality as part of the context. Yeah, I know we don't do sushi for Super Bowl. And so how do you begin to think about a fix when there is that component? And then Michael provided us with almost like some of the practical playbook, like some of the tools. The data is important, and if data is important, what you might be able to do. So there's a lot of food for thought, but I also know that from adult learning, you've been sitting for about an hour and a half. Sitting is the new smoking, so I'm going to invite you to stand with me. And those of you who know me, you know that I am not a licensed physical trainer. And so usually there is a little bit of a waiver to these exercises that I'm not responsible for any damage that might be caused to any of you. So I thought we would work those muscles that we are likely to use for the rest of the afternoon. I'm anticipating that there's still some more questions to be asked, so I'm going to ask you to start now with your right hand on 3, stretch up really quickly and hold it, and then on 3, bring it all the way back down. Oh, this is amazing. That was almost in unison. This might be an easy group. Here we go, on 3. 1, 2, 3. 1, 2, 3. And then for those of us who are naturally left-handed, you're not forgotten. Let's use the other arm. Here we go. 1, 2, 3. 1, 2, 3. Let's do another set. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Feet block more. 1 more. 1, 2, 3. 1, 2, 3. You know what? Let's do one more. 1, 2, 3. 1, 2, 3. That's it for that. The other muscles I think which are important, I anticipate many of you are actually going to be using the microphone. So that's these muscles so that we can talk. So I'm going to ask you on my ass to clench and then release. Please be aware, once again, there could be some damage to your teeth, particularly yeah. So if you know things about your teeth, please do this, just not so hard. So we're going to clench and then release when I ask you to do that. So I say clench and you clench. We should be able to see the massengers. Those are these muscles right here. Are you ready? If you're not sure, you should put your hand on your jaw just to see it. 1, 2, 3, clench. Release. Doesn't that feel good? Oh, you can feel it. Yeah. 1, 2, 3, clench. Hold it. Release. Just one more. 1, 2, 3, clench. Release. And then the last exercise is one that I think you all want to do. Because you'll be using the microphone, all of us have wanted to drop the mic, right? I made an amazing point, drop the mic. So I'm going to ask you on my command, you stretch out, and then drop the mic. Do the drop with attitude, like look away as you drop it. Are you ready? On 3, 1, 2, 3, drop the mic. Just look away like you. Here we go. 1, 2, 3, drop that mic. Oh, this is amazing. Let's try the left hand, because that, if you're not left-handed. Here we go. 1, 2, 3, and drop the mic. All right, thank you very much. Please have a seat, thank you. You burnt exactly 3 calories. It's a start, it really is a start. All right, so I'm going to start over the questions that were asked, and I'm going to ask you if you have additional questions to note the positions of the microphone in the room, if you have additional questions for speakers. The first question of Dr. Satcher had to do with the Leadership Fellows and how we might actually be thinking about the pipeline for youth to be engaged in this work. And you were asked to kind of give a comment on what that might look like going forward.
Yeah, I'll be brief because I know they want to introduce other outstanding speakers. If I remember correctly, your question was also about policy, was it?
Yes, the policy actually.
Yeah.
part of that fellowship before the conference?
One approach we take is that everybody impacts policy. Now, obviously, the health, well, not obviously, but the health policy fellows are generally people at the doctoral level, either in the PhD or something, and they go through 10 months of health policy training. How do you develop policy? How do you influence policy? But we believe that the more that parents know about how policy affects their children, that they play a role, you know, in the community. And obviously the same thing is true about city councilmen and county commissioners. So all of these groups impact policy, but they do it from their own perspective, but they also learn more about what other people can do as it relates to policy and how together we can influence policy. I think it makes a stronger community. I really do, because believe me, once parents go through a program and they know about how the brain develops at 0 to 5, they have different attitudes about children being exposed to toxins or, you know, poor nutrition. So it's from different perspectives, but they all ultimately impact policy and know more about policy. Harry, you want to add to that?
Yeah, I invite any other members of the panel if you have additional comments you'd like to make.
The only thing I would add to that is, I think what we train not only our health policy fellows, but also community members and others, is to be much broader in how they're framing health policy. So just for example, when you think about health policy in schools, people think in terms of physical activity and nutrition. The fact of the matter is the single most important health determinant in terms of what's going on in schools is successful learning and educational attainment and moving on. So again, recognizing that education policy and housing policy and all those other areas are in fact really powerful health determinants is really important for a mayor to understand, events for our fellows to bring into organizations and agencies, and for parents to understand when they think about their children's health, helping them to be successful in a school setting, in a community setting, is as important around their health as the things we traditionally think about, like healthcare.
Okay, and then there was a question about, as you think about what it took to get us to the eradication of polio, are there a set of strategies that we might consider when we think about trying to eliminate disparities in obesity? And I think there was a specific emphasis on childhood obesity as well. But obesity carte blanche, and maybe if there are any sub-strategies that might apply to disparities in childhood obesity.
Well, unfortunately, we don't have a vaccine. I mean, those of us in public health, the vaccine is probably the best thing that's happening. But, I mean, we have to find something like a vaccine to deal with obesity. And I'm really glad that Dr. Liburd brought up the issue about stress and sociality. You don't understand that? Because I think those are critical. I think they really are. And somewhere in there we've got to find the vaccine for the negative components of those things. There won't be a shot that hurts when you get it. But it will be something in our society that we do together, you know, that allows us to deal with some of these challenges.
Any of the other panelists, any thoughts about what might we do more of or differently to make an impact?
So I just wanted to just say more about, you know, again, how we create communities of support for healthy body sizes, for physical activity. I worry that a lot of things that we do are constructed out of a very kind of middle class perspective that particular communities that have high rates of obesity may not necessarily connect with, which is why I like Girl Trek, but Girl Trek I think is also very much geared to college-educated women because they talk about walking, for example, as a revolutionary act of self-care. I love that. That like speaks to me. But if I said that to my sisters, they're like, okay. I talked about this personally. One of the things I'm very clear about is that being at the CDC has actually been protective for me health-wise because if I wasn't in this environment that was constantly driving home these messages and these issues, if I were really at home in Richmond, Virginia, kind of throwing caution to the wind, it just would not be a good situation. But what I think we have to create are more primary prevention messages. I think that as we are looking at childhood obesity, we also cannot forget the adults in those children's lives. Because I think sometimes we hand them off to the bootstrap when we're very concerned with the children, but they come together. And so as we are grappling with strategies for childhood obesity, I would also at the same time try to think what is the complementary strategy for that the mom or dad or the whole family can engage in. I think when we were talking about churches, that was a cultural community, if you will, that I studied. And there in one city, they calculated that there were like 84 events at churches across the city that had food. So it's only 52 weeks in a year, right? So they're eating in the middle of the week too. And so the church is a good place, but we also come up against this cultural notion of what people call church folk food, right? So that we have to really start, and it's a long-term process. So that's the other thing, we need to make a long-term commitment to changing these things because just like I think from the neuroscience perspective, if appetites and palates and so forth get sort of solidified in the first 5 years, if you're coming into the church and I'm 42, and my kid is 12 or something, okay, we got some work to do, and we don't need to be in a hurry, right? We need to understand kind of that there's an intergenerational dynamic here that we have to get people into really like retrain their brain in terms of what they like, and what they don't like, and introducing new foods and so forth. And the last thing I'll say is about my sister, like whenever they would come down, they would say, now don't cook anything. Like you don't, because they hate her. And they would come, go to the Publix, buy all this stuff, and come and cook it. And I was like, all right. And so now, my sister told my youngest daughter, she said, she'll listen to your mom. Now I've been here now almost 30 years. And my sister has type 2 diabetes. She's now on dialysis. She's lost vision in one eye. She's had all her teeth extracted because of uncontrolled diabetes. And it's this thing, it doesn't happen overnight, it happens over time. And I think we just need to stay in there and continue to fight the good fight and continue to look within our communities and have these conversations about how we can undo these things.
Thank you. I just wanted to offer that when I think about polio, in some ways, and Dr. Satcher, you can check me on this, I think there was a global common understanding that this is a problem. When you start seeing kids who are unable to move, or there's a major challenge, that suddenly the entire world looks on and goes, we can't have this. So there's a global commitment to act. And then that was followed up with everything, kitchen sink, to try and ensure that there's access. And we know that there are still some challenges. And I just wondered if there was anything, when we think about this work, do we actually have a common understanding? Maybe those of us inside this room, yes. But as I think Michael mentioned, there are folks who, this issue of either disparity or equity, sometimes lands really flat just when you start having those conversations, and that can be a barrier from time to time. And so that kind of commitment to act as part of the strategy, when you're thinking about what needs to happen, so how do you get people to that place where there's a real clear understanding that this is a problem, that we need to act together, and that there is a way in which we can provide access to preventive measures, whatever those might be, given the evidence and the science. Anything else? Because I figure you probably also started taking a stab at putting together some of those strategies when I asked, so what do you do? Anything that you would add, what's happening in your state that you'd say, you know what seems to be, maybe if not an extremely effective strategy, but something that looks promising when we start thinking about how do we move the needle? Is there anything that's happening in your neck of the world? And I'm going to ask you if you could just kind of make your way to the microphones. There's one to my right at about 1 o'clock, and to my left, looks more like 3 minutes, just about, yeah, there. And could you once again say who you are before you either make a comment or ask a question?
Good evening.
How are you?
I'm Doralina Sammons Hackett. I'm the Executive Director for the Directors of Health Promotion and Education in Washington, D.C. I think I lost about 3 calories by saying that.
So you're up to 6, good.
and I live in Landover, Maryland, and we were talking before about the church. I know Dr. Satcher talked about the church. And working with black communities, and I can only deal with the community I live in, working from the top, and what the top does is important. So what the pastor does, the people are more generally likely to do if the pastor is doing it. And I said there was a disease called the Black Baptist preacher disease, where they have a big girth neck, wide stomachs, and they all walk around, yes, and hallelujah. That's Black Baptist preacher syndrome. My pastor is about this tall. I don't know how much he weighs soaking wet. He's 55 years old, and he runs marathons. And he now has our church engaging in running marathons, or at least preparing for it. Every Saturday morning, they go out to FedEx Field, where those horrible Redskins play. They go out to FedEx Field, and they walk around, and they do exercises together. They have the students from Howard University coming into the church to take blood pressures and do some assessments. But again, it started with the top down, and our church, 6 years ago, they used to have donuts in between the morning worship and 11 o'clock, and everybody was looking forward to getting donuts, orange juice, and then there were apples that never moved, and coffee. He stopped it. You would have thought that the man had lost his mind. The old people were upset. We wanted something nutritious. So now he started, every time there's a meal at our church, including funerals, it's done with a healthy lens, so that people can get used to start seeing it done and knowing. And for those of you who work with minority churches, you got to start with the pastor. You get to the pastor by dealing with the church secretary. In case nobody told you, that's what happens.
Thank you very much. So I heard inspiring leadership, inspiring and transformation.
I'd like to meet that pastor.
Henry P. Davis III. He's from Texas.
All right, thank you. I think there is another comment or question. Yes.
Hi, I'm Dr. Tyra Norris Ellis from GCAP, Georgia Campaign for Adolescent Power and Potential. And we have a childhood obesity program called Plan, Grow, and Learn, where we go into the 34, well, we're trying to get into the 34 food deserts, because Fulton County has 34 food deserts. We go into the schools in Fulton County and DeKalb County and APS, Atlanta Public Schools. And we provide them with the opportunity to grow a garden, a community garden, so that the community can have access, the students and parents can have access to fresh fruits and vegetables. And we do this on a year-round basis, but we have one problem, and I would like someone up there to address that. We grow fruits and vegetables throughout the year, but during the summer, it harvests. And we have no way of getting them to the students and their parents who need them the most. Do you have any ideas on how to get the food that the children are learning about how to grow and how the community will have access to? However, the children, when they get out during the summer, they don't have access to those fresh fruits and vegetables because they're home during the summer. So how do we get those fresh fruits and vegetables that are grown at the school in those food deserts to the students who actually need them?
Thank you for your question.
So I'm going to suggest that this could be a special project of the PTA, so that, you know, as the parents know that the harvest is coming in the summer, that there can be committees or people with trucks, and, you know, who can actually, you know, have a responsibility for gathering up those foods. And I know that the kids live, you know, all over. It's not like they're in one place, but I think if it could be announced that the foods are available, and particularly if they're free, you know, at certain locations on certain days, you know, I could see parents coming out to do that, particularly like on a Saturday morning when they're out, you know, at the markets anyway.
So we are addressing the health equity part, and food access is just trying to get it to the students once they're out of school. So thank you for that.
But I'm sure there are people with trucks, you know, pickup trucks, and they would be willing to do it, you know, if there were enough, they could spread it over the summer.
You know, I'm sure this is a coincidence, but, you know, I actually went to church this morning. And the pastor said that there's a school over here, and there are 200 students who don't have food on the weekend. So it's like your summer, right? It's when you're not in school, and there are a lot of students suffering that. And so he made it a project for the church. Make sure that these kids, 200 of them, will have food on the weekend. Some people are going to drive, some of us contributed money. So you might want to think about the churches and the community that this is something that can be done. And it's very important. Thank you for bringing that up.
Yeah, and I'd just like to ask you, is the campus open in the summertime?
Yes, the students are not there, like Hamilton Holmes Elementary School, that's here, and they're open during the summertime just for the secretary and the administrators. The students aren't there during the summer. And the principal has sent me harvest of all types of fresh fruits and vegetables, but the students are not coming to pick them up and things like that. So.
Is anyone here from Wholesome Way of Georgia? Okay. Wholesome Way of Georgia is the organization that works with double food stamps at farmers markets, and also works with medical clinics, FQHCs, and some of the free clinics around partnerships with local farmers, so they can get a healthy food prescription they can actually take, and they might be able to help with some of the logistics around that. It's Wholesome Way of Georgia.
Wave.
Okay. Yeah.
All right, thank you for that. There was, Emily, you had a question or comment?
I do. So I think everyone can agree it's a little tense in our country right now. And you alluded to the fact that sometimes these discussions are started and you get a flat line or not a good discussion going. I was wondering if you had any advice for us as leaders or people working in the public health realm to create a safe space for some of these discussions around health inequity, social determinants, etc.
So the question is that it's a relatively tense time in our kind of national community right now, and it was already mentioned that some of these discussions fall pretty flatly when we try and raise the issue. What strategies might you suggest or recommend for the folks in the public health community in terms of making that different? How do you get folks interested in having this conversation? What do you do? Thanks for asking that question.
For one thing, this doesn't completely answer the question, but you've got to start the discussion. I mean, and I think a lot of us just give up when things are not going well in Washington. But if you've lived as long as I have, you know that you can change the way things are going. But it starts with people, you know, at a local level or what have you, beginning to make plans about how to change certain things. I wouldn't give up. And I only say that because I could tell you some stories about the way things used to be, you know, in terms of, well, when I was a student at Morehouse, if you were black, you couldn't eat downtown. You couldn't get a job at Rich's. So, you know, we've come a long way since then. And we have ways to go, but it's tough times never last. Who said that? But tough people do. Yeah, so I mean, I just think we've got to keep pressing.
So I would add to that, since I don't work for the federal government, I'm free of what I can say, and I realize some of my colleagues are more limited. I will qualify, since I work for a state institution, that these opinions are entirely my own and not a reflection of the institution.
So you learned that statement.
So what the conversation we had with our health policy fellows last year, who went through a prolonged period of depression in the late fall last year, and that I also tell students that I teach now, is that I think this is a really important time to stay engaged in the national conversation, not as a debate, but as an opportunity to bring our expertise to reframe that conversation and to inform that conversation. But it's also a time to really pivot at the state and local level and focus your work and your energy there, because I think in spite of the fact that there are a number of things that I would characterize as either stuck or moving the wrong direction at the national level, the national political and policy level, I think the reality is it's a continuing time for innovation and opportunity at the state and local level. And I think that regardless of where people are regarding the national conversation, what's going on at the local level is right in front of all of us. And however we feel, whatever we feel the root causes are, we still need to move the work forward. So I would encourage you to take on leadership roles or expand your leadership roles. I think the importance, as we just heard, of modeling behavior. There's great studies looking at physicians. If you're a physician who models certain behaviors, it's much easier to help your patients and communities with behavioral change. That's true for leaders in public health. It's true for leaders in religious institutions. And I think you can bring your expertise and reframe the narrative in ways that can address root causes. And I'll just add one more thing, and that is, if obesity is your passion, be mindful of the fact that obesity, from my perspective, is just a symptom of the same challenges at the community level and at the social determinants of health level that leads to community violence and many of the other public health challenges that we deal with today. Someone raised a question earlier about urban-rural. There's a lot in the literature about the epidemic of despair that's leading to the opioid epidemic, which most of us know isn't a new problem. People look more like me now, so
Yes.
the people in leadership roles that look more like me are now more concerned. But this is a long-lasting problem that is, in fact, coming from despair and lack of opportunities at community level. So we collectively can uniquely tell that story and frame the response. So I encourage you all to do that.
I just want to make a non-political suggestion. This is something we've been, grappling with in my office. Yes, I do want to repeat this non-political statement. But one of the things we've been grappling with is being able to articulate in a very clear way how health equity is good for everybody. And that really is like countercultural in a sense, in that I think the American ethos is that if everything's okay at my house, everything's okay. But if we can really demonstrate that things actually be better at your house, if we're attending to, reducing health disparities, reducing inequities, that is, I think we talk about safe space, because everybody doesn't want to hear the truth, as Doralina would want to put it forward, right? And I'm not saying that, but that's what I think we need to do, is the safe space is where we both win when we pursue health equity.
And I'd like to just add, even though, let's say, some terminology like health equity, social determinants of health may not be as popular at certain times, that does not give us the license to then back away from what needs to be done. So instead of, this is just conversations that we've had, some of my colleagues, using the term health equity. What's popular now, I've noticed, is this term opportunities for all. Instead of using the term health disparities, what's acceptable to some, it may be the term high burden. I'm still doing what I need to do, but I will compensate and I will do what I need to do to satisfy leadership or whomever needs to be satisfied. But there are some ways that we have to be innovative and creative.
So I see two folks at the microphones. Please, we start this side. Once again, just say who you are, and then go ahead and either ask your question or make a comment.
My name is Karen Womack. I'm with the Mississippi State Department of Health. And I just wanted to offer a resource to the lady who asked the last question. The National League of Cities has a program for, it's designed for, I believe, mayors and aldermen. It's called REAL. And it's about conversations about health equity, and not just health equity, but racial equity in general, that we're trying to encourage our mayors and aldermen to take. So that's the National League of Cities, the REAL, REAL program.
Thank you for that. Yes, ma'am?
I'm Mary Bennett, and I work with county health rankings and roadmaps. And I have this amazing privilege of working with communities as well as my colleagues all over the U.S. And just in terms of the issue of health equity, there's some really great examples of what communities are doing. I know there's a webinar with Jefferson County, Alabama. It encompasses Birmingham. And they did a health, now I'm forgetting the name of it. It wasn't called health equity, but health partnership. There's another word in there, and I'm sorry, I'm not remembering the exact name. But I think I'd love to hear y'all talk about, because what they really did was leverage partnerships. And what we're finding a lot in communities work, especially in addressing health equity, is those using and leveraging those relationships. So it's not just one community, but people working together. And those partnerships are really giving a broader base, speaking in one voice. So it's not just one racial group or one having to be the people speaking up about the inequities, but really asking a broader range of brothers and sisters to stand up. And they've changed policies with their health department where the new employees have to go through health equity training. And so they've really created some fine examples. So there is some really great work going on, but I'd be curious to also hear the panelists talk about, how leveraging partnerships might really be a big opportunity right now with working more locally, since nationally it's pretty wacky.
Any thoughts on that? Local partnerships that might be leveraged to make this happen, given that, as you point out, national looks hard?
First, I think the idea of partnerships is really important in public health. I think it was 1996, we were celebrating the 50th anniversary of the CDC, and we had been working on the whole issue of physical activity. we weren't quite as aware of the obesity epidemic then, before the Surgeon General's report was. But seriously, what we decided to do was to develop partnerships throughout the CDC so that each one of the centers, divisions, would have their own teams, and they would compete as to what percentage of the employees were in fact physically active on a regular basis. And we're talking about, walking, jogging. And we changed the cafeteria so that people who wanted to eat more fruits and vegetables could. And it worked out much better than I think we expected. But it had to do with the fact that people working together in these various divisions wanting to do better than the other divisions. And so it turned out to be what happens when you get people together in partnerships. And I don't know what's going on there now as it relates to that, but I was impressed with how people came together, to compete.
So I think we called it the lifestyle program.
Yes, yeah.
I think it's actually grown and gotten better over the years. But I wanted to say, I can't think of, there's no other way we can do our work except through partnerships. And I think the question is always, do we have all of the stakeholders at the table, right? Quick example, there was a program at CDC I was involved with for a number of years, and I got invited to a meeting where they were going to launch a project to change the city around the university. Some people would call that gentrification. I don't think that's what they want to call it. But I was intrigued. It was the first time I actually heard people lay out how that thing happens. And so what was significant in that they had, a lot of people from the university, they had all the major players at that table. And they had the coalition president for the program that we were supporting was also in the room. And so as they were laying out, you need to do this, you need to do that, she stood up and she said, we want to be included too. Because one of the first things they said was that the first thing you have to do is you have to bring people into the city who have high incomes and who don't have children, right? Because the schools are bad and they're not going to send their children to those schools. So bring those people in first. You're going to get the houses, renovate all these things. And so this woman who was part of that community already, she said, don't forget about us. We want to be part of that, et cetera. And so I don't know, ultimately what it's, because those are things that take years to actually complete. But my hat was off to the university, who our grantee, for including that community coalition in this effort that was going to significantly transform that community in a good way in terms of walkability, access to resources that promote health, and so forth. So let's not leave those people out.
Thank you. Let's go here and then come back to that microphone.
Thanks, I'm back again. So I just wanted to touch on some things that we've seen really successful. I work with an organization called Go Austin, Vamos Austin, GAVA, and we're actually a coalition of residents and schools and community stakeholders in about 8 different institutions and organizations working together. And I think the biggest resource that our work depends on is relationships. So we have actually, in doing this work for several years and starting to improve outcomes, have made the case for funders and our organizational partners to hire organizers, because organizers build relationships that make things happen. So things like, and I've seen firsthand the school garden phenomenon, where you have this great involvement and everybody goes home, and it's an organizer can actually build that team, build that relationship, support that PTA. Organizers also they get the insight, if they're trained well, if they have the analysis, or if they come from the community themselves even better, can hear it, can hear that input and know what to do with it. And one of my table mates, Chanel, made the point earlier on when we were talking about what are some of the barriers She said, you know, a lot of these interventions have these top-down prescriptive approaches, and you get into the community, it's not necessarily what works. And so we actually have to have organizational flexibility, and that's very difficult but worthwhile work. So some organizations have had to completely change their programming because they realized it wasn't actually reaching the people it needed to reach. And in order to have that, and I think across the organizing piece, the institutional piece, and absolutely to what Dr. Liburd, am I saying it right, what you were talking about, there's actually some studies in Texas. We have one of the highest maternal and infant mortality rates. We're with some undeveloped countries in Texas. And some really awesome sociologists have taken enough data to show that it's actually what they talked about, the allostatic load. The actual internalized stress. It's not people's diets, it's not people's lifestyle. How are we focusing our work on the systems and how people walk through the world every day in different ways, not just their individual story. So the tool that I've found to be incredibly transformative in our organization and some of the other work that I do in Austin is working with organizers to bring anti-racist training to institutions, to city leaders, to organizations, to organizers, to community people, and actually get a common vocabulary so we can talk about how we got to these historic inequities. I live in Austin, Texas. This is one of the fittest cities in the country. We have some of the worst disparities, and a lot of people don't know, as progressive as we are, we were the last school district to desegregate in the entire country. They fought Brown versus Board till 77, didn't even start unifying the school district till 83. So, and we still have schools that have never integrated. So those issues, until we have that on the table, and now we're dealing with economic displacement, where people are outside of the areas that serve them, I totally agree. I think you have to look at every single layer of the social determinants of health, but you have to have people who can hear what the directly impacted folks are saying and actually put them in positions of decision making. And our systems aren't set up to do that, so that's something we all have to train and keep working together and networking to do. So I just wanted to offer that, and love to hear y'all's input.
Thank you. Debbie?
Good evening. Thank you very much for being here, panelists. The state of Georgia and other states in the Southeast have received funding from the W.K. Kellogg Foundation to implement farm to early care and education. And the partners are charged with thinking about measures around health equity and health disparity in 2 years. I'd like to ask the panelists to comment on what measures they believe, not just for farm to early care, but many of the people in the room who are doing shorter term intervention work, what measures around equity and disparity might get us our best bang for our buck as we think about trying to generate other support for the work.
Any thoughts on the measures that might help to do this?
Yeah, so the one thing I know that we've done at CDC through the community guide is they did a systematic review of education and early childhood education, and early childhood education being one of the equity metrics, if you will, that's very important in terms of setting children on a trajectory for reducing health disparities. That's the one thing I can speak to from the literature, and so then the implications of that certainly reach beyond education, but ultimately employability and other things that contribute to reducing health disparities.
All right, another question? Oh, one just before that question. I think Harry, you want to comment?
Just real quick, I would just have to ask you a few more questions to respond to that in reference to the communities and the geographic area that you're seeking to serve. And because immediately what comes to mind would be access to fruit and vegetables, income, education, and nowadays safety. So those are some measures that immediately come to mind. But I would have to have a real conversation about what's really going on in the geographic region that you're seeking to serve.
Please.
Hi, I'm Wanda of the Norton Meadows with Little Ones Learning Center here in Atlanta Metro in Forest Park, Georgia. So I'm an early educator. This is my 24th year serving the community. My mother's sitting right over there. So I've been doing this since 1995. My question is, I hear all the awesome dialogue on what needs to happen, ways to engage the community. I very much believe in the relationship approach. But what happens when you have, so we work with Health Empowers, we work with Georgia Department of Public Health, we work with Children's Healthcare, we work with lots and lots of collaborations, and they all make meaningful impacts, because I don't believe that there's any one silver bullet. If you follow this path, it's going to take off. But it does have to be meaningful. We work with Debbie Kidd of a Georgia State. We're one of the grantees with the W.K. Kellogg Foundation as well. But how do you deal with the marketing aspect? So we're doing all this wonderful work. All these organizations, they do come and do things with our children, 0 through 5. We know that early brain development, people learn their behaviors, attitudes, up to 5. A lot of it, and then up to 8. So how do you deal with the McDonald's and these other marketers that are coming in, putting these images in? So what are you doing to, I guess, how do you compete with those, if we're trying to change a generation? Because like my generation, I'm lost, right? I'm still gonna eat my Chick-fil-A on every day but Sunday. That's just me. But how do you, I love Chick-fil-A. But how do you...
I'm sure they appreciate the plug.
So how do you deal with the ones that we're raising now, that they're having, media is a big influencer, whether it's magazines, supersize it, larger, bigger is better. So just curious to hear.
So the question is one about that media influence. So we heard a little bit when you spoke about the sociality and some of what our innards tell us to do, and then there's what the exterior world's kind of putting on us. And the question is, how do you deal with that in those communities that we're experiencing the health thing?
Great question. Turning off the TV is not a bad idea. I think also, to the extent that we know predictably that certain food environments lead to certain food behaviors, and that we know that certain policies lead to certain foods being cheaper and more accessible than others. So I think, I think there are policy opportunities through zoning. So Morehouse School of Medicine, which is across the street from Morehouse College and Spelman and Clark, Atlanta. If you want to go grab something to eat close to there, you have a choice of any of an array of fast food establishments or corner stores. If you want something healthier, you probably need to get on MARTA or get in your car. We know that low-income, racial and ethnic minority communities tend to have a concentration of fast food and corner stores, often without healthy food options, together with lots of liquor stores. So again, I think there are policy levers that can change that. And I think also at the higher level, our farm policy and our food policy, in the same way that for years and years, we as a country subsidize tobacco farmers in this state and others to produce what we know is the leading preventable cause of premature death and morbidity in our country. We still have a totally misaligned food policy structure in our country, where in rural Georgia, it's hard to find affordable, healthy foods because we're not producing local foods for local consumption, generally speaking. We're producing them for export. So I think those are kind of broader opportunities. But I think at the family level and at the institution level, we have control over policies about what foods we bring into our homes, what foods we bring into our schools, and I think at the local and community level, we can also impact policies.
I do want to say, I think Spelman has to be commended because they have made some critical changes. They did away with competitive sports so they could invest in programs that all of the students will participate in and be physically active. And they've made a lot of progress in getting students physically active. They had to give up competitive sports, and that's not easy. And that takes good leadership. And I commend Beverly Tatum, I guess, was the president then. And they also have, when we didn't have fresh fruits and vegetables in that community, and now we do, there's a Walmart that has them. They would have these trucks to come in where people could get fresh fruits and vegetables on the campus. So they had the leadership to make a difference there, and I think they did. I wanted somebody to raise a question about polio that I don't want to drop completely if I understood it. So the point I was making about polio was that, number one, we as a world community share a commitment to eliminating polio and ultimately eradicating it. In public health, we use eradicate when there's like smallpox. There's not a single case in the world. Eradicate it. Eliminate, say we eliminated polio in the United States back in the, I forget, the 70s. So we eliminated when it's no longer in one country, like I mentioned in India now. But why is it that we can get people to work together to eliminate or eradicate smallpox and polio? Because we see the connection. We see that, it can spread from one community to the next. And so we try to get rid of it so nobody will be at risk. But when it comes to health equities, everybody benefits when we achieve health equity. And I think that's the point that we've got to somehow get across. When we achieve health equity, and we go into details about how, but everybody benefits. And so I think we've got to take that attitude, the same as we had towards smallpox and polio, in trying to make sure that we don't create a world, a community in which people are at risk for something that we can get rid of. In this case, we're talking about all of the things that come. Don't forget, we're talking about obesity. But obesity is a major cause of diabetes, heart disease, cancer. We could go on and on. And I think that's the attitude we've got to take.
I concur, sir. Yes, ma'am.
Yes, so Teresa Hill, registered nurse with here locally with Wellstar Health System. I work with community outreach. So my question is, so as we talk about obesity, and I think the question was raised earlier that we all in this room agree that obesity is an issue. How do we get the rest of the society to agree that it's a problem? I've raised my children, but I know social media plays a big part, and we see now with social media more influence with mothers raising their daughters with positive self-esteem, trying to tell them that size is not important. We're seeing more plus models on the runways, and we still see in society where you're labeled as thick and not as obese. So that connection between obesity and the label that it is obese and that there's a health risk, how do you marry those two concepts of teaching young mothers to raise their children with a positive self-image while also teaching them that obesity is an issue and that there are health issues related to that? How do we get that image out there?
So it sounds like this is perhaps a little bit of a follow-up to the kind of media piece that we're talking, which I hear you asking how. What ideas do we have to ensure that we're going down the pathway that we want and that specifically our children aren't necessarily misled into a way of living that gets us to this place. The how is always a very challenging question. But we have a learning panel, so no pressure.
First of all, just to say it out loud, these are very complex issues, and so if you have a mom, and I'm all for protecting children's self-esteem, particularly children of color, because there's so many negative messages that are kind of perpetuated every single day. But there's this other issue of cost, right? Dr. Satcher talked earlier about breastfeeding. I remember being in a meeting and we were talking about worksite health promotion, and she said, so what are we gonna do for, the pregnant cashier who's working at Mrs. Winters? It's just gonna happen to be the example. And when we think about our programs, we're not typically thinking about her, but she's going to have a baby. She may or may not be able to breastfeed or not long enough. She may have to provide this child with processed foods throughout because she doesn't have a NutriBullet and, some of the things I see my daughter and her friends doing. And all of that, the cumulative impact of that, right, is then you get up one day and the child's 5 years old and they've gotten increasingly larger over the years, and mom doesn't really know how to interrupt that, right, because nothing else has really changed about, her life and what she can provide and all these other things. So, then we think about the children who get breakfast at school and lunch at school, and then in the summers, they don't necessarily have, all of these things are happening at the same time. So what I appreciate what Harry was saying is that, we're gonna have to be alert and engaged at all levels, as you understand the complexity of these issues, and as we have our indigenous institutions also, reinforcing things like limited screen time and what have you. But whoever said about how we're going to get our whole society engaged, again, I think we have to take a long-term view, so that, because there is still size discrimination that goes on in, a lot of different settings, right? And I don't know if the science has changed, but there was a time when that we didn't know the life cycle of a fat cell, right? So kind of once you have it, and when you lose weight, it shrinks, but it doesn't really go away. So you're sort of fighting it for a very long time. As soon as you stop doing something, the weight comes, all that, you know what I mean? So we want to be on the end of primary prevention. We have to understand the complexities of all of these things and be able to, infuse public health strategies, policies, interventions, wherever we can, and be engaged in partnerships with other sectors that have even greater influence in some of these issues than we do. So, but we did all that to say we can't just stay with the mom and the baby, because she and the baby are part of a larger social structure that is constructing a lot of these things that we're trying to undo in a good way.
I just want to reinforce that, because I see Emily's sitting there asking questions earlier, but one of the things that with the SHAPE committee is really looking at businesses, or businesses providing opportunities for women, and that could include that teller, even though it's probably going to be a hard case to make. But was it Johnson & Johnson who decided to reward their workers for quitting smoking and losing weight? And when they started off, they were just like everybody else, about 16% of their workers were smokers, and the child's down to 4%. But they reward them. Now, in the case of businesses and breastfeeding, we ought to have some way of identifying businesses that make available to their employees opportunities for storing milk. So when we say breastfeeding, we're not necessarily talking about feeding there, but at least being able to store milk, breast milk, and take it home. So we need to put more pressure on for that, just as we've done with some other things, and have businesses taking more of their responsibility. Just because somebody works at McDonald's, it doesn't mean that McDonald's doesn't have responsibility for seeing that their employees can have healthy babies also.
Just to build on that for a second, Dr. Satcher said in his earlier comments about the data going back decades showing that children who are eating healthy and physically active perform better in school. That's a story to take to school boards and to local schools as a rationale for ensuring that kids have adequate opportunity to be active during the school day, and that there's thoughtfulness about what's being served. And similarly, there's compelling data about the return on investment for companies like Johnson & Johnson and others that have not only incentivized workers to make healthy choices, but have created those opportunities on site for them to do that, both by making healthy choices more available and less expensive, and by creating opportunities through gyms or subsidized gym memberships or other things to do that. So I think, again, there are opportunities at the policy level, family policies, business policies, school policies, community organizations, what you serve between the early service and the late service at the church, to have an impact and change an environment that moves things in a healthier direction.
Can I say one? I just want to make one final comment, because when I listen to myself, and again, this is kind of my whole anthropology thing, where I typically take the lens off of the individual and I kind of look at the social context. But that being said, I don't want to ever, give the impression that we absolve the individual of making the best choices and the best decisions that are available to him or her, but that there is this, it's a bi-directional relationship, that the environment also helps to shape those behaviors. So I just want us to be very sensitive to that. So it's not an either or, but it's a both and.
Thank you very much. I know we're at the end of our time, so I feel like I need to summarize the last 2.5 hours. Wish me luck. So what I think I heard is that this is a complex issue. There are probably multi-pronged, multi-level approaches to thinking about how to address health inequities. It includes thinking really about that socio-ecological model, that there are the responsibilities, the individual, to the broader community. And so how do you actually go about making all of that happen? I'm particularly, I'm leaving here today with kind of a playbook based on what I heard. The question that was asked about, how do you get others who are not yet signed up? In some instances might be diametrically opposed to this work. How do you get those individuals to kind of get to that place where, if we're thinking in the model that got us to the almost eradication of polio, that folks are globally committed, fully understanding, and ready to act in terms of ensuring that preventive measures are in place. And I heard, don't give up. Acknowledge that we're moving forward, because tough times never last, but tough people do. That might be the hashtag of this session. Stay engaged.
I'm sorry, so I won't be stealing anybody's quote.
Yeah, we can find a reference, a relevant reference, but it still makes a good hashtag. Stay engaged in the conversation. Be part of the conversation isn't an option, but maybe broadening your conversational capacity so that the trigger terms that we generally tend to use, we find other ways in which to bring others into the conversation that, they don't get hyped just because you use a word like equity. Focus on state and local levels. Look for leverage that's perhaps not non-federal if it feels hard and it feels difficult, particularly around those partnerships that you already know exist. Expand your leadership role. Be reframers of the conversation and create that safe space for those discussions to happen. And I will end with just an example. I'm part of a work that we've actually had to develop a health equity module that we deliver to multi-sectoral collaboratives who are working on population health and coming up with new and different ways to fund population health. And in that equity module, we have an exercise where we ask folks to pick a perspective. We give them a choice of 3. There is a business perspective for why equity is important. It's profitable. We recognize that there's some folks in the room, that's what matters. What's the bottom line? Don't ask me to do something if it's going to mean that I'm going to start losing money. So from a business perspective, why is it important? From a politically expedient perspective, why is it important? And as you well know, that sometimes is the rub, that there is one worldview, that's another. And the third is the kind of moral imperative. And generally speaking, a lot of folks start out thinking that this is an issue that, how can you be human and not understand that equity is important? And in having the conversation at tables, folks realize that we're not all the same. And that by having listenership, you understand another perspective. And by engaging others, you start to break those walls down. So I would just leave you with that as you think about your work in obesity here in the South and what that means, think about your role in facilitating these conversations. There is no leadership without listenership. And I implore you, as you are here for the next 3 days, that you listen and walk away from the 3 days of sessions with a slightly different perspective about how you might actually begin to move that needle on health equity. Could you join me in thanking our panelists? It was my honor to have facilitated this conversation. I ask you to stand with me as we prepare.
Well, let's thank great moderator. Wow.
There'll be an envelope in your evaluation forms. Please stand with me as we go. Some of you are about to go and eat. If this is not your home city, I implore you, beg you, to go out and spend your dollars here in the city of Atlanta on behalf of the mayor himself. All right, can we just do a little bit of stretching so that you make room for the food? And I'd like for it to be coordinated, stretching if you don't mind. So we're going to go up.